Hey y'all, good afternoon. This is Professor Tasha signing on here to do a couple of more YouTube videos. This YouTube video is actually going to cover upper GI. I know I did this for the Friday lecture in class, but I want to make it available online for those students who have not had an opportunity to get this lecture. And so I'm also going to make this available via PowerPoint, voice over PowerPoint. And so what I'll do is record also on the PowerPoint. I'll put that on Blackboard. So if you need to study that way, you'll have that available as well. What I will do is I'll start from voiceover from the slide where it talks about age-related changes in the older adult for upper GI. So the first couple of slides will not have any voice over on it, just so you know. So with that being said, let's jump into it. I hope you guys are doing well. You're staying hydrated. You're staying inside until this whole thing passes over. So I just want you guys to know that we are supporting you. We're here for you. Focus toward your success and getting through the semester, okay? So with that being said, let's get started. This is actually going to be covering chapters 28 and 29. And again, this is upper GI. I got a couple things going on here, so I might not be looking right at the video every now and then, but just bear with me. We'll get through it. So age-related changes in upper GI. One of the things as the older adult ages is what happens is with the stomach area, there's less hydrochloric acid production available, which leads to decreased absorption of iron and vitamin B12. I did state in class on Friday, but I'll state it here as well. Vitamin B12 in the older adult is actually called the intrinsic factor, and sometimes lack of that leads to pernicious anemia. And so then the older adult needs more foods high in vitamin and also iron as well. Also, we encourage bland foods for the older adult. The next change you'll see as the older adult ages is problems with the large intestines. Particularly, there is a decrease in peristalsis. So, you know, when you have decreased movement there, that leads to constipation in the older adult, which is a huge concern. And so to accommodate for that, there's a couple things as nurses we need to do. Number one, we need to encourage increased activity where able, as much as they can, and also increase of fluids. But you want to be really careful when we're increasing fluids, particularly for patients who may have problems with cardiovascular disease and also problems with kidney disorder. And so if they don't have those problems, then fine, we can give them extra fluids. But we also want to make sure that their diet is high and fortified in in fiber as well. So you want them increased fluids and also increased fiber in the diet. And then you also want to make sure that when we're ordering pain meds, particularly for the older adult with constipation, that we're ordering a stool softener as well. So if the doctor is giving them medications for pain, make sure that they have a stool softener along with that. The next age-related change, and I'm going to kind of slow down here a little bit so that I can get these things out. Pancreas distension. So the pancreas actually dilates and enlarges, which leads to decreased lipase production. And the result of that is fat absorption or a decreased amount of fat absorption and digestion of fat. And so because of that, most of the older adults have problems with or at risk for peripheral vascular disease. And one of the things you might notice in clinical, or may have noticed in clinical in the past, is that you see the older adult most times are often prescribed simvastatin or also Lipitor in order to keep the cholesterol levels down. And so with the older adult, they're at risk for that as well. Hypercholesteremia related to dilation of the pancreas. The liver, the decrease in the number of size of hepatic cells. And so we did talk about in class, my Friday class, we talked about the liver and some of its functions. One of the main functions of the liver is metabolism. and so metabolism of medications, particularly. And so because they have a decreased amount of hepatic cells, with the older adult, we want to make sure that we are assessing for drug toxicity or metabolism of drugs, because they also take a lot of drugs as well, depending on the disorders that they have. They're at risk for the liver not metabolizing those medications properly, and then it builds up in their systems and becomes toxic. Okay, and so we need to assess for signs and symptoms of drug toxicity, which would be increased confusion, encephalopathy, lethargy, and I did say confusion already. And so we assess for that. And we need to make sure that we're doing medication reviews often with the older adult, and those medications that they don't necessarily need, we need to get those DC'd. Data collection or assessment of the upper GI system. First thing we want to do is start with a good history. Okay, one of the things we want to assess for, number one, starting with the mouth, since digestion starts there. Are there any ill-fitting dentures? Do they have problems with chewing food? Do they have problems with swallow? Next thing you probably want to ask about is any history of surgeries related to upper GI. Also, any problems with constipation, any disorders that may be pertinent to the older adult as well, such as GERD, gastritis, all of those different things. Physical assessment wise, you want to make sure that you're doing a good physical assessment of the upper GI. So maybe assessing for any mouth sores. You also want to maybe assess for the abdomen, assess for bowel sounds. You want to assess for any distension, any nausea, vomiting, all those things you want to assess for, and many more. Okay, I won't go through all of them there because you guys should know physical assessment really well. But if you have any questions about that, or if that's not clear, just send me over email and we'll get that taken care of. Okay. Diagnostic studies that are specific to the upper GI system. Number one, the most common thing that they'll do is an abdominal x-ray, depending on the complaint. And so if there's a complaint of a continuous nausea, vomiting, pain, they may order just a flat plate of the abdomen. If that is not conclusive or it doesn't show anything, the next thing they'll do probably is a CT scan or MRI scan or ultrasound as well, where it take a closer look. And one of the things you want to be really cautious of or know as far as nursing consideration is you want to assess, number one, for informed consent, to make sure that they are informed of what's going on. Also, the questionnaires that you do, particularly for MRI, any metal in the body. CT scans, you want to make sure if it's with contrast, then we have considerations for medications such as metformin. Make sure that we get that DC. Other studies of the upper GI, probably pertinent, or we'll talk about later, is the EGD, particularly when the doctor is looking at maybe diagnosis of GERD. They'll do an EGD study. If they are looking at bleeding ulcers in the stomach, they'll probably do an ERCP, where they'll go in and take a look and do what's called cauterize any bleeding that's going on. One really familiar GI or upper GI assessment that you may be familiar with is a colonoscopy. So they do colonoscopies when they're looking for polyps. And so each adult should have one starting at age 40, okay, 40 to 45 they usually do them. And so, with the colonoscopy, there's prep that needs to go with that. Usually the day before, the patient is given what's called Go Lightly prep in order to clean the GI system out. And also, the patient is warned about eating anything with red dye and nuts in it and things like that, so it doesn't alter the result. That leads us to the first disorder of the upper GI system, which is stomatitis. Stomatitis is basically, essentially what it is painful, single or multiple inflamed erosions in the mouth, in the protective lining of the mouth. And usually they can be really bothersome. And we really treat these what we call symptomatically. So if there is pain with those, we might encourage the patient to use Orajel or rinsing the mouth with water, not with Listerine. So with water after each meal. Where it really becomes a problem, stomatitis, is when we see it in secondary infections or opportunistic infections. So stomatitis, you have primary and secondary. Secondary is usually seen when we have opportunistic infections such as candidiasis or fungus in the mouth. Usually seen in patients who are immune compromised, so patients maybe with cancer, patients with other immune disorders as well. Also, it's seen in patients with vitamin deficiencies, particularly if the patients have increased amount of alcohol intake and they don't have those vitamins they need. You'll see mouth sores and things like that. And so with these individuals, we want to encourage them to stop the smoking and stop the drinking. But to treat the secondary stomatitis, might treat it with things such as nystatin swish and swallow or swish and spit, okay? And so that's when they just, it's a really yellow liquid solution that the person just gargles in their mouth and either just spit it out, okay? Let's talk about a little bit about nursing assessment for individuals with stomatitis. So with stomatitis, for nursing assessment, first thing we want to look at is risk for infection. And so we're going to look at those sores and assess for it. Is there any extra drainage? Is there any extra swelling? Is there any excessive pain? It is going to be bothersome, but I'm talking about excruciating pain here. After the assessment, we're going to look at medical treatment, which I talked about before, antifungals, which is nystatin, antibiotics if the sores are infected as well. And then we're going to do what's called dietary changes. So bland diets, not a lot of salts, not a lot of spicy foods, just to give the sores time to heal. Complications that we might see related to stomatitis will be probably dental erosions, bleeding, and if it gets really, really bad, the person probably will stop eating, and so they'll have some weight loss problems and also malnutrition, and then, of course, infection as well. And so for those complications, then we need to make sure that we're doing a plan of care for these patients, which will include INOs for the weight loss and also soft blend diets that they can eat and tolerate, and then increase intake of water. Okay, so not a lot of the sodas, juices, so just water for that. As I get ready to go into the next disorder, which is GERD, I want to encourage you, if you have questions, please write them down, send them over to me in the form of email. If you have any interesting patients that you may have seen when you were at clinical before, or you've seen this in practice, share those with me and I'll share them with the group, and we can talk about these things when we get online in our Friday class or Monday class, whichever class you're in. Those of you who are listening from Professor Margaret's class, send her over emails, questions about anything that you might have a question about. You can also email me as well, okay? But Margaret probably would be your first source of contact if you're the Racine group. So GERD. GERD is the most common upper GI disorder in the United States. And basically what it is I want to turn this camera around so I can show you this picture. You have a picture of it as well. But the esophagus here, you have a lower esophageal sphincter here that's weakened. Here it is right here. That's weakened, which causes acid to come up from the stomach up through the esophagus, and it burns the esophageal area, which causes the distress with GERD. GERD usually is aggravated by the diets the individual partakes in, and also it can be aggravated by smoking as well. In your book, on page 653, there are a couple of measures that we suggest for patients with GERD. Be really, really important for you guys to take a look at that. You might see this information on exams in the future, but make sure you are aware about dietary alterations for individuals with GERD. So avoiding high fat foods, and you want these individuals to eat 4 to 6 small meals per day. Have the individual to eat slowly and chew their food thoroughly, and avoid using a straw for liquids to decrease belching and also reflux. Particularly, you want to eliminate foods with citrus juice and also chocolate. So chocolate lovers, they need to get away from that. And then we want to make sure that this individuals are able to wait 2 to 3 hours after eating before lying down. Okay, if the person is overweight, we encourage weight loss, and then at nighttime for them to sleep with the head a bit elevated. So I just want to point those out to you, which are very, very important things for individuals with GERD. The next slide talks about some manifestations that you may see with GERD, which is outlined out really good in your book and on the slide. So I won't read through those, but you can take a look at those as well. Really, really important, medication therapy. Also in your text, page 651, there are a couple of classes of medications that will be really important for you to know. H2 receptor blockers and also proton pump inhibitors. So if we were in class, particularly my class, I would ask you some examples of those. But since we're not, I'll give you a couple that'll be really important to know. Number one, Zantac or ranitidine. That is the H2 receptor blocker that acts by suppressing acid secretion and also blocks H2 receptors on the parietal cells. Okay. Patient teaching is going to be really important. So these drugs should be taken with the meal and at bedtime. Once a day dose should be taken at bedtime. And then advise the patient to avoid cigarettes, aspirins, and other NSAIDs. Advise to avoid alcohol or only consume it in moderation and only in conjunction with food. Advise to use stress reduction techniques as well. And so that's for H2 receptor blockers. Other class of medications is proton pump inhibitors. Your proton pump inhibitors, of course, are your Prilosec or omeprazole. Action is they suppress secretion of gastric acid and may cause headaches, nausea, vomiting, or diarrhea. Use is preferably limited to 4 to 8 weeks, so this is not long term. Okay. Patient teaching or nursing implications: follow regimen of diet and stress reduction of ulcer, and stress reduction for ulcer healing. So it's used for ulcers as well. I want to see if there's any other medications on here. The other medication that you're probably going to need to be familiar with for this exam as well is Carafate. Carafate is used as a protective coating barrier for ulcers. So it's also used for ulcers as well, not only GERD. You want to take this as directed and wait 30 minutes before taking any other drug with that medication. So those three medications, omeprazole, ranitidine, and Carafate, really good to know about. And so if you're following along, there is an NCLEX style question there. I won't read it. You guys can read that and go through that. I just want to go through the disorders. Hernias, hiatal hernias. One thing that is really, really specific about hernias, you'll notice that individuals with a hernia usually also have GERD as well. And so what hernias are loss of muscle and strength and tone. and a protrusion of the stomach through the esophageal area of the chest. And most clients are asymptomatic to have hernias. So hernias are not really a problem unless you're either lifting or eating the wrong foods. A couple of things that we need to teach our patients with hernias: number one, weight loss. So if it's because of, if they're overweight, want to encourage weight loss. And then also no lifting. On your slide, it gives two different types. You have a sliding and a rolling. I wouldn't be too concerned about sliding or rolling. The really important thing to know is you want to make sure that that either one, whichever one you have, number one, that they're asymptomatic unless active, unless aggravated. So you want to make sure no lifting, and also weight loss as well. Also diets, spicy foods, and also chocolates, things like that. The same considerations for GERD. You want to use those for hernia as well. Gastritis, which is the next upper GI disorder. Gastritis is simply inflammation of the gastric mucosa, which is the stomach lining. Can be either scattered or localized. It causes ulcers as well. A couple of things that we do to diagnose it. We look at, again, EGD studies or ERCP to look for gastric bleeding or GI bleeding, which is hallmark symptom of gastritis. Patients with gastritis, they either have acute or chronic. And what they'll see with acute is rapid onset of epigastric pain or discomfort, also nausea and vomiting. Normally, nausea and vomiting, it'll be like coffee ground emesis, which is indicating a GI bleed as well. Also, they'll see dyspepsia, which is heartburn, and also anorexia, so they won't have an appetite to eat as well. Chronic is a little bit more vague reports of epigastric pain. Individuals with chronic gastritis, they're usually not the quickest to come to the hospital because they've had this before and they just kind of tolerate it. But when it gets really bad, they usually come in, and they're coming in with nausea and vomiting as well. Also, specific to chronic gastritis is pernicious anemia, which is a lack of vitamin B12. So whether it's acute or chronic, we kind of treat it the same way. If they come in because of a flare, first thing we're going to do is we're going to put this person in PO. That's one thing you're going to notice with a lot of upper GI or lower GI problems. When they're having nausea and vomiting, the first thing you want to do is rest the abdomen and make them NPO. Next thing you want to do is probably give them IV fluids because they're probably going to be dehydrated. So we're going to be doing fluid replacement as well. And then we're going to probably give them IV protonics because they're not going to be taking anything by mouth. And also, they may get Zofran or Compazine for nausea and vomiting. So make sure, just a little teaching point here, for Zofran and Compazine, that you know what that is for, and that's to treat nausea and vomiting. It's usually really effective. But then just know the side effects from that as well, and adverse reactions. Adverse reactions to both of them is going to be like blurred vision. Not really a lot of side effects, but just that adverse reaction you might want to just make note of. Slide 16 of 30 has a class activity, and it just says, how is gastritis different than stomatitis? And so you may want to think about that. If you want, you can send me over an email, give me your answers for that. There's not any points associated with it, just for your learning. gastritis presentation, and also stomatitis presentation. If you were in class, one of the things we would talk about is gastritis is more is upper GI. Stomatitis is more local and it's in the mouth. So that's the biggest difference. But one of the ways that they are alike is that they can cause what we call anorexia. And so the person may not want to eat or cannot eat. With stomatitis, because of the sores, it may be painful for them to eat, and so they're at risk for anorexia that way. Gastritis, because of the nausea and vomiting, they also may be at risk for anorexia, weight loss, and all those things. I'm trying to see if appendicitis is in your book. Let's see her. It may be in chapter 29. So let me just take a look at here and see. Ulcerative colitis. Appendicitis. Yes, appendicitis is going to be covered in chapter 29. So actually, this is a lower GI problem. So now we're talking about a little bit of a lower GI problem. Appendicitis is usually inflammation of the appendix, and treatment is removal of the appendix to prevent rupture. Peak incidence is 10 to 12 years, and it begins as a dull, steady pain in what we call the periumbilical area, which is right in the middle of the umbilicus. Hallmark of appendicitis is rebound tenderness and pain at McBury's point, which is in the right lower quad. And so what happens is, as the practitioner or healthcare professional palpates on the right lower quad, a rebound would be the individual's left foot will actually jerk. And so that's called rebound tenderness. Signs and symptoms of appendicitis. Number one is going to be excruciating pain. Patient might have what's called projectile vomiting. They'll have a low-grade fever, of course, and then I believe I said vomiting, but nausea and vomiting as well. Labs you'll see is an increase in the WBC count, and clinical symptoms are usually used for diagnosis. Again, we treat this with what we call abdominal sonogram and explanatory lap, which is just removal of that appendix. Before surgery, pre-op, the patient needs to be NPO. If there is an abscess present, we'll give antibiotics prophylactically as well. As far as heat, you should not be putting heat on the stomach to relieve the pain. And we don't want to do that because if there's sudden pain relief, this may indicate a rupture of the peritonitis. A rupture of the appendix leading to peritonitis. Peritonitis, what is it? Usually is inflammation of the peritoneum. Some risk factors for that is abdominal surgery. And of course, we already talked about perforation of the appendix. That's a risk factor. And then ectopic pregnancy as well. Treatment goals is to identify the cause. Number two is to alleviate the cause. One of the things they do is an NG suction. And what that does is decompresses the abdomen. And when that happens, the person experiences a marked relief in pain. Another thing that we do for individuals with peritonitis is give them antibiotics and normal saline with potassium as well. We're going to be watching that white blood cell count to make sure that it's come down, because that's going to be elevated with peritonitis as well. And then, of course, we're going to do what's called rest the bowels. These individuals are going to have decreased bowel sounds because of the peritonitis. And so they need a lot of rest as well. with this individual, you want to make sure that as soon as they're able, that we want to get them up and ambulating, because immobility causes more problems, as you know. Bowel obstructions are really a huge problem, particularly when we're talking about the older adult. Bowel obstructions, there's two different types that are listed on the slide, but before I begin to talk about that, I want to talk about what leads to a bowel obstruction, of course, which is constipation, severe constipation. Usually constipation comes from a couple of things. Number one, immobility. Number two, it can come from use of pain medication, narcotics. That's why I encouraged before, if a person is going to have a pain med, that we make sure that we couple that with a stool softener, some Miralax, anything like that to keep the bowels moving. Another reason obstructions happen is because of past surgeries, maybe abdominal surgeries, where there is, I guess, scar tissue there that causes the obstruction. One of the things that we want to be aware of is the higher the obstruction, the quicker the symptoms. And so sometimes what you'll notice with individuals with bowel obstruction is they'll have nausea and vomiting, but in fact they'll be vomiting bile. And it'll be a really distinct smell. If you've ever smelled it before, you'll never forget it. So what else is familiar with these patients, or what's specific with these patients? They're going to have high-pitched bowel sounds at first, and then they go absent. And if we were in class, I would ask you, how would we indicate a person has absent bowel sounds? And that's, of course, that we're listening to in each quad for 5 minutes. And so before we can say that this person has bowel sounds, that needs to happen. That assessment needs to happen. How do we treat an obstruction, or how does the doctor relieve of obstruction? I'm glad you asked. One of the things they do is NG suction. And what they notice is once the NG goes to suction and the stomach is decompressed, the patient will notice a marked improvement in pain, because this is very painful for patients as well. And so that's usually what they do inpatient. If the patient is in long-term care, though, we just give them tons of laxatives until we remove that obstruction. Really important, though, if we're treating this in long-term care and we're using laxative, X-ray KUB must have to happen in order to see if we relieve the obstruction. That's easier to do in acute care than it is long-term care, because we have to order those things. But in any event, in order to see if the obstruction is relieved, we need to do a KUB, okay? Usually they do a KUB before and then after treatment as well. Again, I'm skipping the questions. You guys can read those and go through them. If you're reading the questions and you're concerned about what an answer is, send me over an email and I'll get those answers to you. If you have a question about a rationale, that you can send over to me as well. The next disorder we'll talk about is inflammatory bowel disease. There are two disorders that are specific to inflammatory bowel disease that we'll talk about. One of them is ulcerative colitis, and the other one is Crohn's disease. I want to talk about ulcerative colitis first. Ulcerative colitis is actually inflammation with formation of ulcers of the mucosa of the colon. So it's inflammation of the colon, in fact. And it's a chronic disorder. Usually it's asymptomatic unless it's flared up. Okay. Couple of things that we do to assess for this. We look at a WBC count that is elevated, and then what we call an ESR rate, or a segmentation rate, is elevated. And that segmentation rate is simply a measure of infection. Also, we look at the hemoglobin, which will sometimes be decreased, because we'll notice with ulcerative colitis, the individuals having excessive bloody and diarrhea stools. Okay. Also, they have mucus drainage with that as well, abdominal cramping, malaise, and anorexia. All right. So how do we treat it? In ulcerative colitis, we're going to use antibiotics and also resting the colon and the bowel as well. Crohn's disease. Crohn's disease actually has what we call a genetic predisposition, so it runs in families, and also it has an autoimmune component as well. And so with this one, you have excessive also bloody stools, but not as much as ulcerative colitis. So it's fewer, but there's still problems with bleeding. With this patient you'll notice with this patient abdominal cramping, weight loss, fatigue, and then also low-grade fevers. How do we treat it? With this one, we're going to treat with Flagyl and also what we call methotrexate. Methotrexate is usually given just one time a week. And we're going to monitor for bleeding as well by doing that hemoglobin. One of the things that we want to prevent, which is a complication of both, is colorectal cancer and toxic megacolon. And so we want to control the disease to prevent problems with cancer. On the slide, there are a couple of visuals that you can see, a normal colon and then the colon with ulcerative colitis, where you notice there's just pus drainage throughout the colon, which is indicative of this ulcerative colitis. For this presentation, there is a slide in there on I want to say cholecystitis, which we're going to skip over. Okay. For this purposes, I'm having some problems here. Hold on one second. Ooh. Sorry about this, guys. Just bear with me. We're going to skip over cholecystitis because we'll talk about that in the next slide. Also, we see on here, we talked about Crohn's disease already. Colonoscopy. So, not colonoscopy, colostomy bags. Sorry guys, this is a lot. So colostomy. So sometimes, depending on bowel problems or lower GI problems that the patient may have, they might have to get a colostomy, or we might have to create a diversion for a stool passage. So we'll put a colostomy in. One of the biggest changes with this is body disturbed images, and this is a big adjustment for patients. Assessments for colonoscopy is going to be, one of the assessments is going to be the stoma. You want to make sure that stoma is a nice pink color. If the stoma actually ends up to be purple or black or necrotic, that is a problem, and we need to get that person to the doctor right away. So fluid volume deficit, that's one of the biggest problems for persons with a colostomy. And that is because they're sometimes depending on where the colostomy is placed in the colon, the stool can be liquidy or formed. The higher up the colostomy is, the more liquid, and the closer to the rectum, the more formed the stool is. And so one of the things we do is want to make sure that the individual is having adequate amounts of fluid intake, and also that we're monitoring electrolyte balance closely. So for that, we're going to look at changes also in BUN and creatinine levels. Remember, I told you the BUN level, which is 7 to 20 in your book, is indicative of dehydration. Creatinine shows us problems with kidney function. So if the creatinine number is going up, the kidney function is going down. Colostomy care, we want to make sure that the person is engaged and willing to participate in this. If not, they may not be adjusting properly, and then we need to assess for that as well. We want to make sure that they understand how and when to empty the bag. And so we want to empty that bag before it gets really full, because as you know, as healthcare providers, if it gets really full, it may burst. And we don't want that to happen. Also, we want to encourage the individual to manage dietary changes and know the type of foods that cause odors. And so individuals who have like a dark green leafy vegetables, that may cause odors. Also, individuals who eat a lot of fish, eggs, asparagus, and garlic and beans, these foods also cause odors. We want to make sure that popcorn and seedy foods, that they abstain from those as well. I think that is going to be it for this slide. So if you have a chance, go ahead and review this video. Add the channel so that you can get notifications when new videos come up. Want to make sure that you guys are continuing to answer your NCLEX style questions. Also, that you're continuing to do your readings. And if you have any questions, send over an email to either myself or Professor Ace. And we'll be happy to help you, okay? So I'm going to take a break for a little bit and then come back later and do some more videos. Talk to you soon. Bye-bye.